Hello and welcome back to the Neurotransmitters. I am your host, Dr. Michael Kentris, and we are here to be your source for everything related to clinical neurology. I am very happy to introduce, like I always am, one of my former instructors, Dr. Shilpa Reddy, from Vanderbilt University Medical Center. But oh my gosh, I apologize. What is the name of the children's facility on Vanderbilt's campus?
Monroe Carell Jr. Children's Hospital at Vanderbilt University Medical
Oh my
Center.
gosh, there was no way I would have remembered that. I'm so sorry.
No, that's okay.
So I was really happy to hear from you. And the joke I always like to make, right? Child neurology, it's basically just neurology, but for smaller people, right?
Funny that you said that because we have a lot of, and we'll get into this, but we have adult neurology residents that train on the pediatric side and pediatric residents that train on the adult side. And we're so used to people saying, aren't kids just little adults? And I had one of the trainees tell me, aren't adults just big kids?
I think that's probably the more accurate one.
Yeah.
So first off, let's start with broad strokes for people who may not be familiar with the specialty. How does one go about becoming a child neurologist? And once you are one, what do they generally do?
So everyone starts out in medical school. So you do your 4 years of training in medical school. And when you start thinking about what specialty you want to do, I've kind of seen two different types of people that go into neurology. Some people really love the actual brain anatomy, physiology, and they will try to decide between becoming an adult neurologist or a child neurologist. But then I've also seen people come at it with their pediatricians at heart, and they really love working with kids and being with kids. And so they come to neurology through the pediatrics route. So it doesn't matter, I guess, how you started, but just more where you end up. So when you start applying for residency, if you are on the adult neurology path, you will apply to a 4-year program at a ACGME accredited university. And that generally consists of 1 year of an internal medicine residency program, and then you do 3 years of neurology training. Within that 3 years of neurology training, you'll spend, I think, somewhere around 6 months doing child neurology rotations. And then on the flip side, if you are a pediatric neurology resident, you apply to a 5-year child neurology residency program. And you will do your first 2 years being a general pediatrician under their training program. And then your last 3 years, similarly, are neurology. You'll spend, kind of depending on the program, anywhere between 6 to 12 months doing adult neurology rotations. And the rest of the time, either doing peds rotations or research or elective time and things like that. So those are the kind of two big pathways. And then as a child neurologist, as you're going through your neurology years, there might be different aspects of the field that you're more drawn to. Epilepsy is one of the most common diagnoses, or seizures or epilepsy are the most common diagnoses that we see as child neurologists. I think the data shows somewhere between like 60 to 70% of a child neurologist practice is some sort of seizure disorder or epilepsy. So you'll find that people, if they're drawn towards epilepsy and seizures, they can finish their 5 years, practice as a general neurologist, and still have a big chunk of epilepsy in their like day-to-day practice. But there are also some people that are super drawn towards epilepsy and see that passion towards more complicated forms of epilepsy and or wanting to learn more about advanced management options, whether that's the ketogenic diet or doing surgical things. And you'll find, or on the flip side, we'll see people really be interested in neurocritical care. And it's not that you have to do epilepsy to do neurocritical care, but again, we're noticing that in both adult and pediatric ICUs, there's a high incidence of seizures that we are learning more about detecting and how treatment affects outcomes. So I think it is, some people will choose to do an epilepsy fellowship along with their neurocritical care fellowship to help kind of round out their training. And so we'll see people come at it from that way. So if you are interested in either epilepsy surgery or neurocritical care, EEG, people will do an extra year or two of fellowship. If you're not interested in epilepsy or you are more interested in other things, there's a lot of other diagnoses in the pediatric neurology world, such as demyelinating disorders, movement disorders, neuromuscular disorders. We have some people really interested in headaches. Those are kind of the big, and then stroke, of course, pediatric stroke. So like I said, within child neurology, you're probably going to see epilepsy and seizures on a day-to-day, but if you're more interested in a specific aspect, it's kind of nice to know you can do fellowships that usually last about a year after the 5 years of training.
Excellent. Now, obviously I'm biased. So I did my like neurophysiology / epilepsy training at Vanderbilt, and I was very fortunate to spend about a month or so on the child epilepsy service. And I had this one distinct memory in particular. It was like it was one of the first days I was on service, and I think was it Dr. Patterson, perhaps. I might be getting the name wrong. I apologize. But it was a child who had a history of Lennox-Gastaut syndrome, and I was looking through it, and I was like, oh, there's a lot of epileptiform discharges. The EEG is pretty abnormal, but I was like, I didn't see any seizures. And she's like, oh, are you sure? And she's like, what about this? And there was like the little flattening there, sort of the electrodecremental response, if you will. And it's like, oh, each one of these, like 5 per page, is a seizure. And
Yes.
and I remember distinctly, she's like, don't worry, all of our adult fellows missed that initially. And I was just
it's so funny that you just said that, because the fellow yesterday reminded me on her adult fellow on her first month of peds, there was 2 back-to-back EEGs where there was multiple spasms on the EEGs, and she's like, I didn't see those. But I always say, that's why you're here. That's why you're in training.
Right. And now here I am, God, 7 years later, and I still have that core memory with me.
Yes. This is a little editorial, but I do feel like by quote unquote missing things or getting something wrong, in a situation where you have support is the best way to learn, because as high achieving people as we are, you're going to remember a time that you felt embarrassed, or a time where you didn't have that knowledge, or, so at least for me, I think that's an interesting way to learn.
Yes. That kind of emotional tag to the learning experience. Now, as you mentioned, right, you are one of these people who is more engaged with seizures and epilepsy, in fact, instructing more junior physicians in becoming better at it. But just like with adult neurologists, we know child neurologists are kind of at a premium across the country. There's definitely not enough people with the expertise kind of scattered, especially, uniformly across the country. So it's not unusual, right? People have unusual spells or episodes. And if we were to talk to like the family medicine doctors or the pediatricians out there who are, providing most of this care, this primary care, what are the things that you would say they should look out for that might warrant more investigation?
Yeah, I love this question because, as you mentioned, neurologists, both adult and child neurologists, are a limited resource in our country. And we know that care is not evenly distributed in different parts of our country. So I think the more that we can empower providers in other areas besides our academic centers that are in bigger cities, then I think we're going to do justice for our patients. So whether that means trying to, again, educate the primary care providers about how to treat certain conditions, but mostly education about when to refer to like a bigger epilepsy center for care, because we don't want them to wait 6 months for surgical evaluation. We want them to be able to come sooner. But we also, on the flip side, don't want patients to miss out on opportunities for surgical management, because other providers are trying 5, 6, 7 medications before thinking about surgery. And both in the adult and pediatric populations, we know that early surgery leads to improved outcomes. So more than ever, we want to be able to streamline the referrals and the workup and, of course, the treatment. That kind of starts at the beginning. So I can speak mostly for pediatric patients and that streamline, just because I don't see adult patients in my clinic.
Absolutely, yeah.
But, we try to do continuing medical education seminars for general pediatricians in our community. And the focus is on, again, seizures being a big part of child neurology. We focus on how to identify seizures and seizure safety, things like that. So for our general pediatricians, I think knowing that seizures can manifest a lot of different ways clinically, that kind of opens a door. So if a patient comes in with weird behavior, weird episodes, we really should be digging deeper into okay, tell me more about this episode so I can put them in a bucket of this is seizure, this is not seizure. And I start with really asking as many details as possible. So starting at the beginning, what were you doing when this episode happened? Then what did you feel? Then what did you feel? And then if there's a witness or a bystander, kind of asking the family or sibling saying, well, what did they do next? What did they do next? And then what happened at the end of that episode. And it's also important to interject and say to the patient, how much of this did you remember? Did you black out? Because that can help kind of put us in one category or the other. And then going beyond that and saying how many times did it happen? How long does it last? Because like I said, there are a lot of things that look like seizures that aren't seizures, but then there's also some strange episodes that end up being seizures. So kind of getting as much detail as possible so that if you are able to connect with a neurologist at some point, you can give them as much as a story. Nowadays, we have cell phones at our disposal. So we often ask family members or even teachers, if it's a younger kid, to take videos with parents' permission. Because we always say, like, pictures are worth 1,000 words, but videos are even better. So,
it's so true.
We as humans like to say we remember every single detail about things in the moment of stress or panic. And to your point, getting emotion into it can alter the way that we describe things or remember things. So videos are great.
Absolutely.
So I think the big things that a pediatrician can be looking out for is there sort of a loss of consciousness or altered awareness during the episode. So we encourage family members to ask them to do commands or have them talk to them during it. We look out for things that are very stereotyped, meaning does the episode happen the same way every single time? Yeah. And then beyond that, I don't know how much detail we want to hear, but like I said, different types of seizures can manifest different ways. So one of the most common ones that we think about are absence seizures, and it can really go both ways. So we see a lot of referrals for kids that stare off or zone out. And it's really tempting for everyone to say, this is an absence seizure because they're staring. And this is the type of seizure we know is associated with staring. So what I would say is it's really important to test responsiveness in these patients. And even though absence seizures classically are very, very short, the zoning out or the staring off is unresponsive. So if you were to touch the patient's face or give them a little pinch, tickle them, they shouldn't be able to respond or break out of their episode. Whereas kids that zone out or space out, if you startle them in some way, they might not respond verbally, but they'll at least either shake their head or blink or kind of tend towards you. So that's an important feature. And then for absence seizures, I think something to remember is some kids can have some motor manifestations where they flutter their eyelids, might have a little bit of lip smacking, potentially even something with their hand. So that might distinguish that too. So the tricky part is ADHD is a very, very common diagnosis in kids, and it usually starts being clear around that school age, 5, 6, 7 years old, which also is the age where absence seizures tend to be, the onset. So it can be very difficult to tease out the ADHD staring and attention from absence seizures, especially because we know kids with absence epilepsy more commonly have ADHD or higher incidence of ADHD. So if I can take a detour here. So there is an app that's being developed, which I think kind of goes, I'm sure you've talked about AI and things on your podcast, but there's a lot of healthcare technology that we can start incorporating to our practice. And I'm super excited about some of it. Being able to reach more people or being able to diagnose earlier, I think that's great. So this app is a hyperventilation app. With absence seizures, they tend to be induced by hyperventilation. But we often, it's hard for kids to participate in that type of thing, especially if we're not right there coaching them through it. So the app basically coaches the kid to hyperventilate using some fun, techniques. And then there's a little camera that looks at the kid's face, and they can, I think, uses an algorithm to track if they have eyelid fluttering or if they have pauses in their breathing and for how long. And then it'll be, sent to somewhere where the neurologist can review it, or there's an algorithm that reviews it, and then it spits out a report saying, hey, this kid had 3, they can't call them seizures, but 3 episodes where there was behavioral arrest or eyelid fluttering. And then the neurologist can look at it, or even a pediatrician, if they have this app in their office, they can look at it and be like, oh, well, this looks concerning. Let me send them to the neurologist, if that makes sense. And I think it's a nice way. You can use it twofold. One is pediatricians can help triage the referrals for staring. If it doesn't show up as anything, maybe they go down the ADHD path, or they can see the neurologist in a couple months. But if the report spits out and say, hey, there's 3 episodes that sound concerning for seizures, they can call the neurologist and say, I need this kid seen for an EEG in the next couple weeks, And then neurologists can use it because if we have a kid that has absence seizures, then we're starting medication and we want to monitor the response to treatment. We can have the family do this at home and say, okay, well, we still had episodes, maybe we need to up the medicine. I don't want to wait the 6 months before my return appointment. So I think it's exciting, and I hope that starts being incorporated into practice in the future.
No, that's really neat. It's not something, right, I would have thought about, because
Yeah.
I also get many consults in the adult world for staring spells / absence seizures, and I have to say, no, that's for children.
Yes. And even so, I would say, a large portion of our patients in our pediatric epilepsy monitoring unit come in for staring spells that end up not being seizures, because kids, like I said, they zone out, they have inattention. It's just a common thing.
Right. Yeah, I know in the adult world, nearly half also end up being non-epileptic. So it's one of those things that when you go into the field, you're like, oh, I thought I was coming here to take care of epilepsy and seizures. It's like, well, there's a lot of other things that are in the kind of the orbit of those diagnoses that you end up being the person best equipped to handle.
100%.
I was just going to say, sometimes I feel like more more than an epilepsy specialist, you're kind of like a spell specialist.
Yes, that's a good way of saying that. Well, so in that same vein, there's a lot of things that can look like seizures. Syncope is one of those that's fairly common in kids and not dangerous per se. Psychogenic non-epileptic spells, I'm sure you've had a podcast on that. I think that's super important to talk about. But just understanding the sequence of events and the responsiveness of a patient can help any provider really think about, is this in the category of non-epileptic or the category of seizures? So, yeah. A lot of different interesting episodes, but videos have been great. I again, with families' permission, I've had communications and relationships with pediatricians where if they can just send me a video, I can triage that pretty quickly, rather than putting it in the queue to maybe I'll see you in 6 months when we finally have an opening. Helps.
No, absolutely. Yeah, triaging is so important, and as you said, the video, not always, but very often, can provide such good insights to someone who knows what to look for. The semiology is what we in the biz call it, but basically just the clinical manifestations of the event. And it's one of those things where, I consider in neurology, the movement disorder specialists to be kind of the grandmasters of this. But I feel like we're maybe second place in terms of looking at an event, what's happening. It's the story of the spread of an event or of a non-epileptic event as well. And it's one of those things where I really appreciated my training at Vanderbilt, where I kind of think of it as the athletes who would run tape after a game, and they're watching, it's well, did you notice this? No. It's all right, let's go back again and we'll watch it again. And you just do it over and over again for hours every week. And it really just drills into you, making sure that the mind recognizes what the eyes are seeing, if you will.
Yes.
And it's kind of one of those weird skills that you don't really think about, but becoming a trained observer of a phenomenon.
Yes. Yeah, we have we're fortunate to have a lot of practice, like you said. I mean, there's been studies that show different levels. So if you're a patient versus provider versus family member, and are you a neurologist, are you epileptologist, and the accuracy of detecting a non-epileptic spell versus a seizure, it gets a little bit better and better as the more training that you have. But we're honestly we're good, but we're not perfect by any means.
No.
But it's interesting.
I have been fooled more times than I care to think about.
I think I was fooled today, in fact. Yeah.
Every day is a new opportunity.
Yes, for learning.
Yes. So, you are in an instructor role, and as you mentioned earlier, there are certain kinds of people who are maybe attracted to the specialty. But what kind of skills does someone accrue in particular in a child epilepsy training program, or just a general, more neurophysiology epilepsy training program that might give them a leg up in these kinds of particular patient populations?
I really love this question because I've been asked this a few times as applicants have been applying to our fellowship program this year. And they always ask, what are you looking for in a fellow? And I was like, okay, let me tell you. Michael Kentress. No. Only half joking. But really, honestly, as an epileptologist, I think you hinted at this, you really need to be detail oriented. So although in order to triage patients to our clinic, we want to get kind of a big picture of what the story is and what these episodes look like, the semiology. What we are looking for when we're analyzing seizures is like the nitty gritty of, okay, did their face turn this way for 1 second before their eyes went? Was it their left hand that was doing a dystonic movement versus a rhythmic movement versus, so there's so many details that help us pinpoint exactly where the seizures are coming from, which is going to be really important to, if we wanted to do surgery and take that area out, that is like the first step. So very, very important to be detail oriented. That even drills down to when we're reading the EEG. Let's say it's not epilepsy surgery, it's an ICU patient. Being able to describe the waveforms in a way that if I sent this report to you, Michael, you would be able to draw this out. I think Dr. Pagano maybe told you that too. You should be writing a report where I could take it and draw the EEG and it looks exactly like the one that's running. So I think that's a very good skill set to have. I think as an epileptologist, you really need to be curious. I think in every field, there's so much more to learn, but I can only speak to epilepsy. And I think there's so much more to dive into. I talked about kind of the health tech part of things, but there's also more to dive into in regard to surgical devices that are being implanted and how we're actually looking to cure epilepsy rather than treat epilepsy. So having that intellectual curiosity is super, super important. And then I think this is generic, but I guess I want people that are interested in learning. And I don't know if that's the same as being curious, but I want them to be engaged. I never want to take anything for face value, I guess. So if you're an epileptologist, you're always thinking about what else could this be and what else can I do for my patient? I think we do everybody a disservice if we just say, okay, return patient on your meds. They're happy. Let's go. Bye. I think there's always something to be not actually changed, but something to talk about and discuss and make sure that you're engaging with the patient for more than just their seizures. Like, are we talking about quality of life and mood, their social situation? Because again, you can have a whole podcast about living with epilepsy and what that means at different stages of life. So I think that is kind of what I mean by pushing a little bit deeper with learning and curiosity.
Yeah, no, I think I'm sure that you've seen some of these lectures of the year with Dr. Ben Badis. I might be mispronouncing his name, from Florida,
Mm-hmm.
but he's always, maybe you get that referral and you got an EEG report that shows sharp waves in this, that, or the other area, and there is sometimes a bit of skepticism, right? You have to trust but verify,
Yes.
if you will, and so I know we certainly see that same thing on the neuromuscular EMG side of things. And I would say at least to the same extent on the epilepsy side of things, where, it really becomes a question of like, do I know this person and do I trust their clinical judgment as well? And I know that sounds like a bit of a hard-nosed take, but if you just, as you said, accept it on face value, more often than not, you end up getting burned a little bit. Yeah.
That is a very good conversation. I had it with one of our fellows multiple times this year. I like the trust but verify. I think that's a great outlook on life. And I think it's a very nice way of saying that. So
it's probably the nicest way I could say it.
Yes. Just to be completely transparent, there are patients where I will read the patient in August and I'll say, I think this is a arousal pattern from sleep that's totally normal. And then we read it again 6 months later, like the same me. And I say, oh no, this is definitely a frontal lobe seizure. So that's happened a few times in my career, and I would be surprised. I'm sure it happens to everybody. So I think it's okay. It's okay to look at things with a different lens, whether it's you or one of your colleagues or another institution, Right.
And that is the really challenging part, I think. So for those who are not, I'm going to get into the weeds for just a moment, if you'll indulge me. But the phenomenon what we call like over-reading or under-reading EEGs, that is, say, calling something abnormal when it's normal versus calling something normal when it's abnormal. And I think we all go through phases. At least when I've worked with residents in the past, like the first couple of months, right? They miss everything. They don't pick up on any abnormalities whatsoever. And then after they've done a few months of reading EEG, then like everything's abnormal. Like is this a central spike? No, that's a vertex wave. And like all these things, right? You kind of go through these waxing and waning phases where you're like, undercalling, overcalling. You just bounce back and forth through the extremes until hopefully you wind up somewhere in the middle. But there's still those cases where it's just like, I don't know. This one's it's a little funny looking, but I don't have enough data to say, like, does this correlate with every episode the person has? Right.
Yeah.
And to your point, maybe you get that second study and now you have this and you're comparing it to your past one. And it's like, well, this changes the entire lens that I was looking at it through.
Yes.
So it's not necessarily that it's now abnormal as much as like putting these two pieces together gives you like a bigger picture of the whole.
No, I love that. And I think there's so many pearls to be said in this. One is, I think I'm known as a master hedger in EEG reports because I don't like committing to something. If I myself have a little bit of doubt, I don't want to put it down there that like I'm 100% sure that this is, like you said, abnormal or normal. So I think it's better to talk about it because you need the clinical context and sometimes time. Things declare themselves, right?
Absolutely.
And then the last thing you mentioned about, you said
getting the pictures in time. Yeah.
I think that is the hard and nice thing about reading EEGs, because I will say I've been on both sides where I read my own EEGs for patients that I see on the inpatient outpatient side. But there's a lot of times where I read studies for my colleagues who are non-epileptologists on the inpatient service. And so it's tempting to like want to change my read because of something they said in their notes. But without seeing the patient, I think I try to be as quote unquote clean as possible in my EEG reads, if that makes sense. You want to be as objective as possible because you want your data that you're adding to your clinical picture. Each data point should be objective so that when you put it together, then it's your turn to interpret.
Right. And it's funny you mentioned that. So after I graduated fellowship, I was at an academic institution for a few years, and I remember one of the chief residents at the time said, like, you need to change the way that you write some of your impressions because the hospitalists don't know what you mean, so they're consulting us on this basically normal report.
Yep.
And I was like, oh. And so that is right. You have to keep your audience in mind. Who is going to be reading this? And I know that's one of the things that they emphasize a lot. And so I actually ended up shifting around so that like the most generic aspect was at the top. So that if you wanted to get into all the nitty gritty details, you had to scroll past the actual impression, which I think stopped a lot of those consults. But it was this thing where it's just like, this is just the way I've been doing it, and it's not working in this environment. So I had to change.
That's smart.
A little bit of how I put the pieces together, and change the verbiage slightly, right? There's a lot of synonyms that we use, like epileptogenicity versus, various other things, or seizure potentials, et cetera, et cetera. And know your audience, I guess, is the main takeaway for people who are writing reports, whether it's EEGs or anything else.
Yeah, even when we get MRI reports from neuroradiologists, like they all, I think the point is you have clinical context is important or clinical correlations recommended.
Absolutely.
And I find it interesting with trainees in general. I think the point of doing more training is for you to know what you don't know. And I think as a trainee, it's just natural for us to say, well, I need to know this, I need to know this, I need to know this. But as an attending, the further that you step out, it's really easy for me to say, hey, I don't know that. And that's okay. Whereas like, you don't know that point when you're a trainee. You think you know everything. But as you mentioned, like we're humbled a lot of times by new information, and, things don't fit in a box always.
I know. It feels like every time I'm asked a question anymore these days, I have to start with, well, it depends. I can't just give an answer anymore. I've reached that stage of my career.
I know. I think I got feedback a couple of years ago from the residents, and they're like, Dr. Reddy doesn't like commit. And I'm like, it's really hard. Like when I don't have data to say, this is the 100% right thing to do.
Yeah. That really, I mean, that's medicine, right? It's just, the practice of medicine. It's because we have all these big highfalutin studies, but when you try and break them down to an individual, sometimes it doesn't always work the best.
Yes, I totally agree.
So, we've talked a little bit about kind of like EEG training, epilepsy training, spells in children. One thing that I always think is a little unique and it seems a bit challenging, at least from the adult side, is when we have these kids who grow up and they start to age out of the child neurology clinics. And obviously a lot of kids with epilepsy, they do grow up, they reach adulthood, and then they have to eventually find an adult neurologist, which, let's just say, I'm aware that there is an ethos difference in terms of the amount of, let's just say, white glove service that can sometimes be found in it. And what do you find are the most helpful things if you were going to say talking to a family or even to an adult neurologist who's getting one of these people, children with epilepsy who are kind of like hitting the 18, plus mark, and they're coming into your clinic? What are the considerations, especially for the more, let's just say, not straightforward, not like your juvenile myoclonic epilepsy, or people with maybe some intellectual disability, et cetera?
And we know that based on, studies, papers, literature that's come out, that transition between pediatric and adult for medically complex patients, not just epilepsy, but, in all realms, is super, super important. When it's not done well, we see a lot of patients lost to follow-up. We see more ER visits. We see more just like healthcare expenses, all that, depression, quality of life suffers. So one, I'm really glad you're asking that question, because we need to have awareness that this is a problem, not just here, across the world. But there are some clinics and institutions that are doing a really good job with the institution of with transition clinics. And what a transition clinic includes is obviously that support from the adult neurologist or epileptologist, as well as the pediatric side. But it also gives support from like a social work perspective or case management, somebody that is there to figure out, okay, how do I make that insurance transition? As most of these kids have conservatorship from their parents. They need adult, guardians to take care of them. They don't have decision-making capabilities. And then also a psychologist, because there's a lot of probably emotional stress and trauma from the caregiver side. And if the patient is aware enough, that might be hard for the patient as well. So having multidisciplinary support when you make that transition. It's also kind of a physical challenge to get all these people in one space. It's also, just to be totally frank, there's going to be billing and financial issues that come from sharing the resources, so to speak. So as much as I say it's really, really important to do this, it's not that easy to actually execute. But the first step is talking about it. So I'm glad you brought it up. And what I do personally is I start prepping patients when they are 15, 16 years old and start saying like, okay, as you get to that 18, 19, 20 years old, we need to start thinking about, one, what does life look like? So are they independent? Are they going to go to college? How are you going to learn to take your meds and get follow-up appointments? Going to be safe with sleeping, safe with, alcohol and drug exposure, like sleep deprivation. All these things are super important when you're not living under the roof of adults that are telling you what to do. And then for patients that are not independent in terms of daily activities, what does life look like for the caregivers? They're not going to be in school every day. So are they going to be in a group home? Are they going to be in a work program? Things like that. So I start asking those questions around like I said, 16-ish. And then when they're 17, 18, and they cross that technically being an adult age, I always give 1 or 2 visits of, okay, at the next visit, we're going to try to identify somebody that you want to see in adult neurology, whether that's in the same institution or finding somebody closer to home. So at least it gets them thinking without dropping this surprise on them and saying, okay, you're 18, bye, because that can lead to a lot of emotional stress and tension. And as you kind of hinted at, some of these families, because they've had epilepsy for a very long time, they become attached to that specific provider. Mm-hmm. And so it's a relation. It's hard to say goodbye on both sides, like for us and for them. So I think just trying to bring it up slowly and gently at a few different points is good. I always find that if I can refer to a provider that I can, what's the word? That I
vouch for.
Yeah, vouch for. Exactly. That I know personally. Then I can say, oh, you should see Dr. So-and-so. They're going to be really great with your daughter or your son because they're kind or they're funny or they're super smart or they're gentle. Like whatever it is that I think that patient needs is I'll try to connect them with a provider that's going to be a good fit. Does that make sense?
Yeah. A personal recommendation.
Yeah.
No, that's excellent.
Not everybody's for everybody. We all have
This
different
is
styles.
very true.
And then I guess I do want to hint on this because we're kind of tying together education. People always ask when they're applying for this fellowship, like, I'm a pediatric neurologist or pediatric epileptologist. How do I run the adult and pediatric epilepsy program? Because I kind of live in both worlds. And I always say, like, epilepsy is a lifelong journey. It's a lifelong story. So if you see a patient that's 35 and they have temporal lobe epilepsy from like a structural cause, or maybe even not a structural cause, more than likely they probably started having seizures when they were younger, maybe a teenager or a kid when they had febrile seizures. So you need to understand their journey of how they got there. On our side, as a pediatrician, I need to understand that when I have a 5, 6, 7, 8-year-old that has intractable epilepsy, I want to be able to treat that now so that when they are 35, like, what does their life look like if they continue to have epilepsy that's with this frequent of seizures? Or can we do something now? Or let's say you are trying to counsel a 17-year-old about a new diagnosis. Like, are they going to outgrow this in 2 years, 5 years, 10 years? If I don't understand the life cycle of a particular diagnosis, I can't tell them, like, oh, you can have kids, or you are never going to work. Like, it's just, I need to understand it, right? So when we train both adult and pediatric neurologists, epileptologists, they get exposure in both worlds to not so much that they're going to be seeing these patients every day, but just understanding where they came from or where they're going.
Right. Getting the big picture.
Mm-hmm.
No, I to be honest, I have found that super helpful in my own practice as well. We don't have as much like generalized epilepsy or epileptic encephalopathies in the adult population, but it's not unheard of that we get someone in their 40s or 50s who has Lennox-Gastaut, went through the whole cycle with West syndrome when they were younger, etc. And so they come in on a fairly complicated regimen of anti-seizure medications, which can be a little intimidating if you're unfamiliar with all the interactions and the levels and all the the pharmacology in play. So I would say, like, it's there's the whole spectrum, right? The diagnostic aspects with reading the EEGs and being familiar with what do all the squiggly lines mean? And then knowing the existence of the syndromes, and then knowing the pharmacology for the treatments, and then the surgical treatments that we didn't hit on a lot. That's an entire conversation too. But what are the options, right? And I think this is just the tip of the iceberg. We're talking just about pediatric epilepsy, but this applies to all the subspecialties within neurology. There are all of these things beyond even what we know, that all of these our subspecialty colleagues in each of these fields are experts within. And it is one of those things where medicine at large and neurology, and then each subspecialty of neurology is expanding at such a rapid rate. It's nigh impossible to keep up on the latest advances in every field. It's a very Herculean task.
Absolutely. It kind of takes me back to one of my first rotations as a medical student. I was on a rotation, and the clerkship director said, the biggest mistake you can make as a doctor is not asking for help when you need it. And I think that kind of touches on what you're saying, is if I don't know these subspecialties exist, if I don't know this treatment exists, I don't have to be able to do it. I just need to know that I need to call somebody else.
Right. Yeah, and I think that's one of the things I love the most about the neurology community, is that everyone is so welcoming, and it's so great to be able to reach out to people who helped me become the neurologist I am, and other people who I've interacted with over the years, or who I've even helped train early in the residency, and then they went on and did different specialty. I can call up my former residents and ask them, like, hey, you're a neuromuscular guy now. What do you think about this? Does this sound like something? And get advice myself.
Yes.
So it's very good to have this network, this community of people that you like I said, you can trust, whose clinical acumen that you helped form, you've seen it in action, these people are reliable. It's such an invaluable resource. It's just being able to reach out to people and ask their opinions.
I couldn't agree more.
Any final thoughts that you would have for people who might be maybe considering child neurology or even pediatric epilepsy as a future specialty?
I would say for child neurology, just know that there's a lot of different options and spaces that you can be in, even after doing residency training. And the same goes for being a pediatric epileptologist. We train two different types of epileptologists. One is they want to do surgical epilepsy, stereo EEG, device implants, all that kind of stuff. And then we also train equally as many people that go into a practice where they are not doing surgery and they're not at a level 4 epilepsy center, but they are providing really good care for their patients because they know, of course, like how to read their EEGs and interpret them, but they know when to refer for surgical management. And I think we need just more child neurologists, more epileptologists. We need more of everybody so that we can reach as many patients as possible.
Absolutely. If people want to find out more about your work or your work at Vanderbilt, where should they look? Should they track you down online? How would you recommend getting in touch?
Don't come to my house. But so we have a X, the old Twitter,
formerly
account,
known as Twitter. Yes,
formerly known as Twitter. It's at VUMC PEDEPILEPSY. At VUMC Ped Epilepsy is our handle. I'm the one that runs the account, so feel free to reach out to me or DM me that way. Our we have a website for the fellowship pages at Vanderbilt, on the neurology website.
We'll put the link in the notes.
Yeah, that sounds great. I was like, I don't know the link or anything, but I think if you're specifically interested in coming to Vanderbilt or just like learning about what I do, then I think DMing me on X would probably be the.
I know it just doesn't sound right in the mouth, does it?
Yeah, it doesn't. It doesn't roll off the tongue. But yeah, I think I've connected with a few people that way, and I think it's nice to kind of start the dialogue, and then we can email or chat on the phone, whatever people are interested in.
Awesome. Thank you so much. You can also find me on X. I'm at Dr. Kentris, DrKentris. Or you can follow the neurotransmitters at neuro_podcast and check out our stuff on the website at theneurotransmitters.com. Dr. Reddy, thank you again. I really appreciate you taking the time to talk with us today.
Thank you, Michael.